Hello everyone, I am Dr. Karthik Rajan. I am a urologist who's currently working in the United Kingdom, doing my training in uro-oncology. So Dr. Anton had asked me to do a few sessions on some oncology topics and BPH. So we'll start off this session with retention of urine, basic management of urinary retention, and the management of BPH. So it's not going to be a detailed session where we go through everything. So most of it is in the notes. What we will be discussing is the key concepts and strategies and the reasoning behind the decision making you see here. Obviously, if you've got any doubts, then feel free to get in touch with either Dr. Anton or post your questions on the WhatsApp groups, and we'll try to address them, or we'll address them in a separate video later on if you feel that there's something you need that's been missed out. Okay, without further delay, we'll go into the topic of urinary retention. It's a fairly common problem, one of the most commonest that you see as an emergency in urology, and some say it's the only acute emergency in urology. And retention itself, you have two types, and what call it an emergency is this acute retention of urine, which is sudden onset and it's usually symptomatic. You also have chronic retention of urine, where symptoms develop over a period of time and the patient generally does not notice it, and many times it's detected when you do scans for some other reasons, or patient presents with just some incontinence and you find out it's overflow incontinence due to a full bladder. So causes for retention, they're all listed there. Most of them are fairly straightforward. It's written as BOO, which is bladder outlet obstruction. It's just synonymously used here with BPH. Again, if you use BOO, you can have both BPH and prostate cancer, which are both at the bladder outlet, to be included in the same stain spectrum. Urethral stricture, again, more of an issue with men than women. What women get is distal urethral stenosis, which is just some stenosis of the urethral meatus, which is mostly seen in postmenopausal women due to reduced estrogen. Other things that can cause blood clots, urethral calculus or bladder calculus that blocks the urethra, any neurogenic problems or age-related issues, post-spinal anesthesia, fecal impaction, any perineal pain. Most of these can cause retention. So no matter how or what causes retention, management is essentially the same. You need to establish drainage of urine, which can be the urethral catheter, which can be the suprapubic catheter. These are the two techniques that you use, and most commonly it's a urethral catheter that we use to treat retention initially. So you need to be able to differentiate between acute and chronic retention, mainly not because it's different how you treat it, because of how you follow up these patients and how you plan their definitive management. So acute retention is what everyone classically describes. It's painful, you get a tender, palpable bladder, and you use a 14 French or a 16 French catheter. This many times you see people using 12 French catheters, which is not very advisable. but the size of the catheter itself is not an issue as long as you get a catheter in. And obviously, for acute retention, if the etiology is postoperative or due to perineal pain, then or phimosis, sometimes these can resolve with just some warm baths, running a tap, and suprapubic hot fomentation. We call these as episodes of near retention. It mainly suggests that these patients can go into retention at some point in the near future. So these are the people you should be trying to manage faster. What are the checks that you do? You've done a catheter, always measure the post-void residual, or rather than saying post-void residual volume drained. So that's the bladder volume that you drain. It sometimes can give you an idea if it's of few things. If it's very high, like over 2 liters, then these patients are at a higher risk for diuresis after the catheter. They're also at a higher risk of hematuria after a catheter, which is essentially decompression hematuria. And also, these patients are more likely to fail at walk or trial without catheter when you do it very early. So these patients, you probably give them a week or two for the bladder tone to come back to normal before you decide to take the catheter out, if it's for simple BPH or postoperative retention. More often than not, acute retention, it's between 500 to 1,000 ml. It's generally not more than that. So you put a catheter in and you check for the abdomen, rule out any pelvic mass, check the lower limb reflexes, check for neurology, check perineal sensation. Sometimes these can be the presenting feature of cauda equina syndrome. So that's why you make sure you check neurology. Then you do a DRE, estimate the size of the prostate. Sometimes when you've got a very big bladder, it can cause you to underestimate the size of the prostate. That's why you do a DRE best after catheterization. Also, when someone's presenting with acute retention, it's not very comfortable if you do a DRE when they're already having a painful bladder. So that's the acute retention. Chronic retention, on the other hand, is long-standing, it's painless, it gradually develops over time. Most patients are not aware of this. What they usually present is with nocturnal incontinence at times, or recurrent urinary tract infections, or sometimes even just some incidentally detected on ultrasound scan for some other reasons, or worsening when they have an ultrasound for worsening kidney function, you find that they've got a large bladder. Essentially, the clinical findings are essentially the same, and the treatment is also essentially the same. Catheter, but these patients are most likely to have hematuria. They're also likely to most definitely will have post-obstructive diuresis, like in acute retention, where it's very unlikely unless they have very high residual volumes. And they need to be admitted, observed. So the concepts of post-obstructive diuresis will be dealt with in a separate video class, but essentially there are two types, physiological and pathological. For both, treatment is admit, monitor their output, make sure you replace not all of it, but at least 75% of the urine output. And if the output's more than 200 ml an hour, then you replace it with IV fluids, preferably in the form of half normal saline. If they have upper tract dilatation, that settles down in a few days once the bladder is decompressed, but these patients cannot have the catheter removed because once they end up with chronic retention, or what if they have bilateral hydronephrosis, it's called as high pressure chronic retention, where the pressure in the bladder exceeds, the pressure in the bladder is more than 40 centimeters of water. So that's more than what the BUJs can cope with, and it causes dilatation of the upper tracts, which means they will have surgical treatment. So that varies on what it is. If it's a stricture, it could be based on what the management for the stricture would be. If it's BPH, they will need surgical treatment, and they cannot be managed medically.